We are.
Good evening, everybody. We are starting our live for the day. Uh, I I welcome Professor G.V. Manohar sir from Pondicherry, sir. Sir, good evening, sir. I welcome Professor Srinivasan, head of the department from Karuna Medical College, Palkada.
Good
I
evening,
welcome
Srinivas.
Professor
Good evening.
sir from Savita Medical College, Chennai. Uh, and of course, my dear Robin from Tiruvalla. Good evening and welcome. My friend Keshav Prasad from Mangalore and Australia, Professor Honorary. Manoj sir, thank you very much for joining. Because of his initiation, all these things are happening with Robin, George, and Muthukumar sir, Keshav, or with good and support for these sessions. I welcome, thank all of you faculties, and I welcome today's presenter Nandana and Jitya Das from Medical College, Palkad, final MBBS students, and all viewers. I welcome all viewers for the current session. Today we are discussing about the swelling, that is the parotid swelling presentation. Without wasting much time, by welcoming everybody, faculties and students who have joined this live session, and we'll straight away go ahead with the presentation. Over to students. Sir, we'll let them present now, sir. Manohar sir, Srinivasan sir. Nandana, who is
Yes, sir.
Yes, sir.
Who's presenting the history, ma?
Sir, Jitya,
Yeah, you know.
Jitya is presenting the history.
Okay.
So introduce yourself.
Thank
Yeah,
you,
present.
Sriram sir, for the myself Jitya and here Nandana. We are final year MBBS students of Karuna Medical College. Here to present a case presentation on parotid swelling under the guidance of Dr. Srinivas sir. And thank you for providing us the opportunity to present on the online platform. It's a great, immense pleasure. So let me start the history first.
Pretty next.
So, Mrs. X is a 57-year-old female hailing from Coimbatore. She is a homemaker by occupation. There's a swelling in front and below the left ear for 7 years and history of presenting illness. The patient was apparently normal 7 years back, after which she developed a swelling which was serious in onset, initially small in size, and slowly progressed to attain the present size in the past 1 year. The patient also complained that the swelling was initially painless, which gradually developed occasional dull aching pain for the past 2 months, associated with headache, which was relieved on taking medication. The negative history. There is no history of evening rise in temperature, loss of weight, loss of appetite. There is no history of dryness of mouth and eye or reduced salivation. There is no history of similar swellings in the body. There is no history of fever with rigor and chills, redness or discharge. There is no history of difficulty in swallowing and breathing. There is no history of pain or increase in size during meals. No history of cough, pneumoptysis, and bone pain. The past history. She is a known case of type 2 diabetes mellitus for the past 6 months and is on regular medication. There is no history of any other comorbidities, no history of previous surgery or exposure to HIV, no history of previous radiation or previous any other malignancy. And family history, there is no history of similar illness in the family, any head and neck cancers. Personal history, the diet is mixed, appetite is normal, bowel and bladder movements are regular, and sleep is adequate. There is no history of addiction of alcohol intake, chewing tobacco products, endocrine disorders, or any other bulimia, and drug intake.
Tell the summary. Go back. Summary. Tell the summary, Jitya. Tell the summary.
Sir,
Summary.
she is a 57-year-old female who came. Yes, sir. History summary. Sir.
Yes,
She is
read
a
it, ma.
57-year-old female who came to. Sir, I'm
Proceed,
reading,
proceed.
sir. Hello. A 57.
No,
A
your
57-year-old. She was
connection is
a
no.
57-year-old female who came to OPD with complaints of swelling in front and below the left for 7 years. The swelling was insidious in onset and gradually progressed to the present size. It changed from a painless to a swelling with dull aching pain in the past 2 months and is associated with headache, which is relieved on medication. So the probable diagnosis is benign swelling of left parotid gland.
We'll go back to the history. Go back to the history. Priti, go back to the history. Back. Still back.
First slide.
First slide. Okay. Here. Okay. Anything to comment on this, sir? Go back. Anything to comment on this, sir?
Thanks, sir.
Next slide. Next. Okay. Hold on. No, back. Hold on. Sir, anything to comment on this, Manoran, sir? Robin?
Nothing, sir.
Keshav? Next slide.
You can add pain also.
Pain is there. You said pain is there since 2 months.
So,
Jitya,
Pain since how
some
long?
pain is there since 2 months. You told. Jitya, you can hear me.
so yes, sir.
Jitya,
Yes, sir.
you can hear me?
How long
Sir,
is
I
the
can.
pain?
Yeah, pain is there. Also in the chief count.
Past 2 months.
2 months.
2 months. You can mention pain of 2 months duration.
Duration we can mention the chief complaint. Next slide.
It turned from a painless to painful swelling.
Nandana, whenever you say size, initially small in size, progress to present size. But what size was it? From what to what? Evolution of, yeah, we want to know from what to what it has gone, no, over the past 1 year.
So initially how it was, yeah.
Patient own words, people words of in fingerprints. 1 fingerprint to 2, 3, yeah, because it's quite a big swelling. It's a very big swelling.
You said last 1 year it has increasing in size. How much increase it has happened? That's what Professor Robin is asking. That is very important, relevant, I think. Or either some size or something you have to mention. Okay. So
Yes, sir.
anything to comment on this headache, sir? Headache. Keshav? Headache, telling headache which was relieved on
You have to tell something more about the pain. Whether it is continuous pain or intermittent pain. What is the character of the pain?
whether it is disturbing sleep or sleep, or some details pain should be asked.
You have mentioned occasional dull aching pain, whether it is due to eating, chewing, or related to anything. Because it is basically salivary gland, no? So
Yes.
try to connect whether the pain is due to what, whether it's on the mechanism of eating, or if the pain comes even in between eating. So that kind of thing, the intensity, whether it is throbbing or dull aching pain or what sort of pain, that you should say. Okay.
Yes.
What about headache? Significant? Just like we have mentioned. Yeah.
Sir, I
Is
couldn't
significant?
hear.
Headache. Is it relevant?
Headache.
What is the duration of headache?
So
Duration.
along with the alternating pain of the swelling, they last 2 months.
So that means
Whether it is a current problem or not relevant. Different.
So
We have to decide whether to give importance for it or not.
okay.
You think it is important or not? To as far as this condition is considered. Headache.
no, the pain, what you are telling, is it related to the glandular pain, swelling with pain and headache, both are together? Always. That is what they are asking. So whenever she, both are always combined.
So the patient developed the pain of the swelling of the gland along with the headache is the same.
Right.
Okay, we'll go to the next slide.
Next slide.
Next slide. Okay, loss of weight. Why loss of weight, loss of appetite?
Due to any kind of malignancy like tuberculosis or infection, chronic infections.
Now the evening, sir has asked, evening rise in temperature, loss of weight, loss of appetite. So malignancy will be common there as first cause, or something benign would be a first cause. Tuberculosis.
Oh, cheap. Why
Classic feature.
dryness of mouth and eye?
Sjogren's syndrome can be
Only-
associated with it.
See your history of fever, rigors, and chill, redness, and discharge.
Like any infections like parotid abscess.
But
Which is more common, Sjogren's syndrome or tuberculosis of parotid or parotid abscess?
is more
Which one?
common.
Abscess.
Sorry, I didn't get you.
Answer
Parotid
boldly.
abscess common. Parotid abscess is more common.
Correct. So we should put that on the
That
top,
should
no?
come- That should come first.
Rare condition should come at the bottom.
And don't put evening rise of temperature, loss of weight together. Loss of weight should come last. Separated. It's a separate sentence. Don't club those things. Okay. We should put it in separate as a separate entity.
Okay, all this history, negative history of asked, no? What
Yes.
do you think you missed majorly? Parotid swelling. What you are the most problematic or most you are focusing on? That history, anything you have asked? What are you missing here?
What history is missing? That's what the professor is asking. Yeah, Nandana, you can also answer. Both can put for answering.
What is the one thing we are worried about in parotid?
Parotid.
Facial nerve involvement.
So what
Yes, put it
history
separately,
you asked
sir.
about? Sorry?
Sir, I asked them to put it separately. It's my mistake. They put it separately.
No. It's okay, sir. I know. I'm sure they will be able to defend it, but it's just
Yeah, you tell me, tell man. Yeah.
Sir, you don't worry. The discussion will yes, sir. Okay.
Do you have any other differential diagnosis for this swelling other than parotid?
So preauricular
Lymph node.
Yeah, tell me, tell. You
Is it
tell
your-
them, they will correct it.
We just want to find out your thinking process, nothing else.
I think their connection is not. Nandana, tell what is your differential diagnosis.
Differential diagnosis. Whatever comes in your mind, you can tell.
So preauricular lymph node is a close differential diagnosis.
Yes.
Absolutely right. No problem.
Correct.
So we'll
So
go
you
to,
have to cover lymph node pathology also.
sir, we'll go to the next slide.
Yes, sir.
Next slide. So, why previous surgery and exposure to HIV? Why you are specifically that? Nandana and Ajita.
So
HIV exposure.
Previous surgery and exposure to HIV.
there is
So there is a close relationship between HIV. There is an increased risk of parotid infections in HIV. They're more susceptible, sir.
Why radiation? Why specifically radiation history?
So parotid is a tumor which has high rate of recurrences. So, and in inoperable cases, radiation is a method that we commonly use. And post-surgery, we usually do radiations.
Okay, that is if it is if patient undergo the surgery, that's okay. Otherwise, per se, what is the idea of what? Just we are asking, why you ask? Just want to know what is the reason behind asking. Because in surgery, there is no reason for every word. It is the only thing you want to ask. I think Honorary will do that. Sir,
So radiation is for what, ma? When radiation is given?
So recurrent.
No. Malignancies. So head and neck malignancies, which is the most common malignancy. Any idea?
Childhood radiation.
Childhood radiation, and another one is squamous cell carcinoma. Suppose the patient had already previously some head and neck malignancy, probably they given radiation.
come on. Then, they can also. Okay. Keeping watch, you should be able to. Okay. Okay. So we'll go to the next
Yes, sir.
topic. Next slide. Right. Which yes, sir. Robin, anything to comment? Keshav?
Yes,
Something?
please.
Okay.
Please.
Some managers run in family, they have probably asked like this. Okay, accepted. So family tree is important in all cases. They should take a family tree. Okay, so always family tree. So next slide. Personal history. Why bulimia and tobacco and is okay. Why bulimia? Typically you mentioned.
Bulimia.
Yeah.
Sir, there is a condition called silidinosis wherein there is non-inflammatory conditions causing parotid swelling.
What is that? Salactasis.
Sorry, sir.
Which condition you told?
So silidinosis.
Silent. Okay. Anything to come with that? Keshav? Bulimia is the
Nandana, you have said drug intake. Any particular drugs that can cause this swelling?
Yes, sir. There are some anti-epileptic drugs that can cause, and the drugs.
Any asthmatic drugs? Patients who are on asthma?
Yes, sir. There is.
what is cianosis and salactasis? Do you know about it? Nitya? Cianosis, what cianosis? Cianosis, salactasis. Cianosis is infiltration of the parotid. Salactasis is dilatation of the aseptic bilateral. It is. Okay, the two conds which are bilateral. Okay, we'll go to next one.
Tumor and
Okay. Summary, anything to comment, Ram? Sir, senior sir or Muthukumar sir?
No, there was you said one is anti-asthmatic. Salbutamol is one drug which can cause coma, and bulimia is overeating. It can produce bilateral salivary gland enlargement.
Yes, sir.
Okay.
Yes, sir.
Alcoholism.
Alcoholism. Okay. History of alcohol you mentioned, no? Nitya, you have
Yes,
mentioned alcohol. Okay. So we'll go to the examination.
Yes, sir.
Examination. Next slide. Vandana, you examination, no?
Yes, sir. Sir, so the general examination of the patient. Patient was examined after taking consent in the presence of a female attender. Patient was examined in a well-lit room in sitting posture. Patient was conscious and cooperative. Her BMI was found to be 23 kg per meter square. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema was absent. Checking her vitals, her pulse was 67 beats per minute, normal rhythm, normal volume, and normal character. BP was 120/70 millimeters of mercury on the right arm, poster. Her respiratory rate was 16 breaths per minute and patient was febrile. Coming to local examination, on inspection, a single hemispherical swelling 3.5 into 3 centimeter that is seen in the left parotid region. It is situated in front and below the ear lobule, lifting the lobule. The swelling extends between the zygomatic curve above and the angle of mandible below. Skin over the swelling appears normal. The swelling decreases in size on stretching the deep fascia. Parotid duct opening on inspection shows no discharge. Deep lobe enlargement not seen on oral examination. Opposite parotid region appears normal and neck region also appears normal. On palpation, all inspection findings are confirmed on palpation. There was no local rise of temperature or tenderness over the swelling. The surface of the swelling is smooth. The swelling was firm in consistency, has well-defined margins, and is benign. Swelling moves freely in both horizontal and vertical planes with curtain sign positive. Skin is freely pinchable. Swelling is not fixed to the underlying muscle. Bidigital palpation of parotid duct shows no discharge or induration. Examination of facial nerve. Facial nerve is intact and nerve involvement was seen. On examination of the upper face, it was found normal, including the orbicularis oculi muscle, frontal belly occipital frontalis, and corrugator supercilium. Coming to the lower face, it was also normal. Buccinated, levator anguli oris, and platysmus was examined. Tailsations of anterior two-third of the tongue was found to be normal. Neck nodes not palpable on both the sides, and movements of the toe was also normal. Systemic examination. All other systems are within the normal limits. CNS was within the normal limits. Respiratory system, normal vesicular breath sounds were heard. CVS, H1, H2 was normally heard. Per abdominal, no abdominal findings was observed. So the provisional diagnosis in this case is the parotid swelling left-sided, which is having a benign etiology, mostly pleomorphic adenoma.
Okay, we'll go back. Go back to the examination. General examination. With the general examination. Go back. Go back. Okay, anything? Comment on this? Keshav, Muthu, Srinivasan sir, Mano sir, Robin, nothing, no? Next slide.
Next slide.
Next slide. Okay. There are no scar.
What is that scar? What is that scar that here?
There is one temple.
That scar, the patient couldn't give any clear history, sir.
Yes,
He
sir.
said probably in the young age he had some scar or something. And when the swelling was started, it was above the swelling.
Sir, you don't
When
answer.
the swelling started.
You don't
No,
answer.
Okay.
Nandana, you are not mentioned scar, no. He should mention scar. Whether it is relevant or not, we'll decide later. Nandana,
Okay, sir. Yes, sir. Yes, sir.
You tell what the history you elicited.
normal. There is a scar.
Okay, sir.
What scar duration you can mention. This is not significant for this value. You can tell later. If there is a scar, you have to mention its size, it is sealed, okay, and those things.
Okay,
And
sir.
that is important. In-order swelling is not very normal. There is a scar. So mention that scar. Whether it is relevant to current situation or not, that can be decided later. Whatever clinical finding you have to mention. Okay. Okay.
Sure, sir.
Nandan and Jitya, you have to mention.
Yes, sir.
Swelling extends between zygomatic bone above and angle of mandible. Okay. Ear lobule in the lobule. Anything?
But one more thing,
Robin?
Yes,
Sir. Muthu, sir.
Muthu.
you mentioned it is lifting the ear lobule. You have to mention one more point to support the diagnosis of parotid. What is that point?
One more.
What is that groove there?
Any groove is there? Any groove?
Mandibular groove obliteration, sir.
Which one?
It is
Mandibular
this retromandibular groove is obliterated.
Oh, that groove is obliterated, no? That you have to mention.
behind the earlobe, you have to mention that.
Yeah, that is important finding.
That
Earlobe will be
so you should mention behind the earlobe.
it's behind the earlobe. Yeah.
Behind the earlobe will complete.
Yeah, it is. So behind the earlobe place will grow. Nutrition is important. Your skin scar. Okay. Next slide. Why this is the on inspection touching the deep fascia, sir? Anybody on that Keshav?
How did you stretch the deep fascia in that region?
What is that
Sir,
fascia?
on opening the mouth, the fascia gets stretched. The parotid is enclosed by the investing layer of the deep fascia, which gets stretched on opening of mouth.
What do you call that fascia?
Is there a described method like this? Because I have not come across somebody describing it that way.
Yeah, stretching for the deep neck it is okay, but
Neck is fine because neck is because in the parotid region.
Parotid is very tough. No,
Tough to do.
Because it's a very small space, no?
very small. You can tell it is deep to fit. And decreasing the size to appreciate very difficult, I think. And how to Robin? I think that is difficult. I think Robin.
Anatomically speaking about the parotid fascia, from where it stretches to where it stretches, 1, 2, is it superficial to that or is it deep to that? 1, 2, which is the muscle that is involved?
Masseter.
The masseter muscle. Like we agree with Keshav sir, we generally don't say this the way you present. Just mention it. Yeah, it increases or decreases. That's all. In size, no, because it becomes more prominent or disappears. That's all. Increases in size, no, it's quite unusual. Then parotid duct opening on inspection shows no discharge.
Yeah, and yeah, neck is normal. Means what you want to do for? Vandana?
Sorry, sir.
You said
Appears
is
normal.
normal. Neck is normal. What you want to look for?
Sir, we are ruling out any lymph node enlargement, sir.
Okay, anything else you want to look for?
The level 2, 3, 4 lymph nodes, sir.
It is there.
These
Okay.
are the major.
Lymph nodes. Other than lymph nodes, anything else you want to look for in this? Salivary diseases.
Sorry, sir.
In salivary links, anything else you want to look for in the neck?
Sir, we will check also the other salivary glands.
That's important. So neck, not only lymph nodes, submental salivary gland also you have to examine. Okay, on its in the submental region you mentioned. Other salivary glands you have to look for. You mentioned about the parotid. Similarly, submental salivary region also you have to inspect and palpate. Okay. We'll go to the next slide, Robin.
Yes, yes.
So that is the photo. There it is. There photo. Okay. Scar is obviously visible. It is staring. It's looking at scar. Okay. You can't make scar. Okay. Okay. Next slide. Okay. All confirmed. There was no logo. Tender surface is no swelling was firm or hard. It is. Is it firm or hard?
So the swelling is firm, sir.
Firm in consistence, well-defined margin as mobile. Anything on mobility? Muthukumar sir or anybody, sir? Keshav? Mobility, mobile, maybe there, I think.
Nandana Vajidya, what is your differential diagnosis? Most common differential diagnosis for a swelling in this region with regard to mobility?
Sir, again, preauricular lymph nodes.
Yes, very good. We are looking for a preauricular lymph node. That is, how will you differentiate that lymph node from a parotid swelling?
So preauricular lymph node is mobile in all the directions, but parotid swelling, it shows characteristic curtain sign wherein it cannot be moved above the zygomatic bone.
Yes, it's actually quite simple. It's basically an anatomy. Always the lymph nodes are deep to deep fascia. Your parotid gland is still deeper down because it's covered with a capsule. So the mobility is very good.
So,
Yeah, it's an anatomy. Very good. Yes.
next slide. Okay, moves freely. You said moves freely in both directions. Keshav, anything to comment on that? Moves freely should be able to.
It's okay. Instead of saying so much, it's mobile with curtain sign positive. I think that should be enough.
It is pinchable. I thought it's touch bilateral palpation duct shows a no danger. When this duct opens up,
Sir, it opens opposite to the crown of the second molar tooth in the upper second molar tooth.
what is the name of the duct?
Stenson's duct.
Okay. Not fixed to the underlying muscle. Which muscle you are interested?
Sorry, sir.
Which muscle? Not fixed to the underlying muscle.
Sir, we are talking about the masseter muscle, sir.
Huh? Masseter. Masseter muscle. Okay, masseter. How do you check that? How you contract the masseter?
Sir, we'll ask the patient to clench the teeth, sir.
Clench the teeth. Okay. It clenches the clenching of the teeth will definitely help. Okay.
No problem. Okay.
So, Ravin, anything to comment?
Bidigital palpation, is it mandatory, sir?
Routinely not.
My doubt. Bidigital palpation of the duct.
I think it's better if you say bidigital palpation and then you ask why, then you tell deep lobe instead
Deep
of
lobe.
telling duct.
Duct.
Sir, I have just a doubt on what Muthukumaran sir asked. The bi-digital palpation and there is bi-manual palpation. So we have bi-manual palpation for the deep lobe and bi-digital for the duct. Isn't that the usual system?
No. I think bidigital palpation for the duct also we do bidigital palpation. For the deep lobe also we do bidigital palpation only, not manual. Only one finger we put use.
So thumb outside and index finger inside and you rub it between the two and
that is accepted. Next slide.
So they should mention about the plane of the swelling, sir,
yes.
Plane of swelling, Dandana.
on palpation. Seriously.
Patient is plane of palpation.
Louder.
Dandana, whatever.
Then you must tell about the surface. On palpation, you must comment upon surface also.
You know, plane of swelling, you said curtain sign is positive.
Curtain sign is
So what is
positive.
the plane? Dandana,
Sir,
what is the plane? Plane of the swelling.
Plane of the swelling.
Whether it's a deep fascia or not, you have to tell.
Okay, sir.
Vandana, you hear us?
yes, sir.
Then go, it's a deep fascia. No, because the plane is positive. It has to be deep fascia because you
It's deep fascia.
deep to parotid fascia, no? Deep to parotid fascia. Okay. Sir, anything to comment on that, sir? Facial nerve intact, upper face, lower face. What are the branches of facial nerve? Vandana, how facial trunk divides? Ureter, mouth, everything.
Temporal zygomatic,
Temporal zygomatic,
And
buccal, mandibular,
upper buccal, lower buccal, and marginal and mandibular.
cervicofacial mandibular. Okay. So from above down, what it is called as? Otherwise, what it is called as? What it is called as?
Pes anserinus, pes anserinus.
Okay, absolutely. Taste, have you checked taste? You really checked? Taste sensation. Nandana, you have checked the taste sensation or just wrote like that?
History wise or any examination.
Have you checked it or just wrote like that? Have you checked the taste? Which all
So
taste?
we'll ask the patient to extend the tongue outside, and we'll ask them to close the eyes, and
Okay.
we'll put salt and sugar, sir.
This one. Okay. Have you done that? Have you done this one in this patient, Nandana? You have done that. Okay. Neck nodes are not palpable.
He had of
Okay. Why movements of the jaw you wanted to check?
temporomandibular joint, if it is to check the temporomandibular joint.
Okay. Joint involvement. There is a restriction of the movement. Okay, great. Sir, anything to comment? Show? Sir, Muthukumar.
I think, sir, for completion's sake, they should describe the examination of the swelling. They should take the nearest bony landmarks. How many centimeters from where?
Yes.
So that routine way of telling, if they say, it will be better.
They
And I
should
think
mention
something
the
about oral cavity examination also maybe.
important
That is
oral
separate.
examination.
Finish the inspection palpation. Separately, you can say that the intraoral examination.
Intraoral examination.
Yes, if there's any ulceration, very important ulceration.
Ulceration.
Any retromolar trigone area, there is some lesion.
Bulge is seen or not.
Yeah.
Yes, I think cavity examination should be written separately. That is definitely relevant. For that matter, any neck or face swelling, oral cavity should be examined. Any lesion in the oral cavity, neck should be examined. Mutual understanding. Okay. So, like Keshav pointed out, oral cavity separately should write. Important. Okay. Okay. And next slide. Okay. Anything to comment on that? Why you want to do examination? Nandana, why you want to do systemic examination?
So, in order to rule out any kind of metastasis, sir.
Okay. Next slide. Right. Anything, sir, anything to comment on this? Muthukumar, sir, Robin?
Conventional diagnosis, do we parotid left side? This is a case of a left-sided parotid swelling that is your site, an identical site diagnosis. How did you figure out it's a benign etiology?
Why you said it's a benign?
So,
But
Sir,
how will I
there are no signs of malignant changes observed in the history, sir.
No, Nanda, guys, the thing is, the whole point is we are in clinical examination and we are giving that this is a benign, your malignant is histopathology. Right? So, usually we just say that it's a case of a left-sided parotid swelling, probably pleomorphic adenoma.
That is it.
Right, sir? Manoj sir, Keshav sir, isn't that how we usually say it?
Correct. 7 years duration, very slow.
Yes,
growth.
then we will ask you what are the points in favor of your diagnosis. Then you can tell us. But benign, we have not done any investigation.
First, we will ask you why do you say it is parotid?
Yes.
Sir.
First, tell me the
Sir,
point. Why that it is
it's in
parotid.
the parotid region,
Nandana, why?
and it has
No, why it is parotid?
1 year rapid increase in the size, how will you explain? Rapid increase in the size in the last 1 year.
So they've given a slow increase in size, and there has not been any change in consistency of the swelling, and there has not been any reason inflammatory changes that is seen over the swelling.
No. You said, listen here, Nitya and Nandana, you said it is in 7 years, and in the last 1 year it has increased in size significantly. So what exactly you elicited? Are you going to give importance of this increase in the size last 1 year or not? What is the reason for that? You understood the question, Nandana?
Yes, sir. Yes, sir.
So why it is 1 year increase in the size?
So maybe it's showing a malignant potential.
Why you are not considering malignancy at all? Do you still want the facial nerve to get involved? Do you still want the lymph node to get involved? only then you will diagnose malignancy, or will you give importance to the increase in the size last 1 year and consider it is malignancy before facial nerve get involved, no? Which is the commonest
Yes, sir.
malignancy in the parotid. Commonest malignancy.
Mucoepidermal
Carcinoma. Here it is probably 7 years, increase in the size recently. So only point is facial nerve is not involved, no lymph node, but rapid increase in size has got some significance. So that you have to take into account. But you are not elicited like Robin has clearly. You are not elicited what is the size difference earlier, and but he has been pointed out in history. That is very crucial. How small it was in 1 year, how big it is. That will give a fair idea about whether there is a malignant transformation. Okay. So that the size is very important. But it has raised that point. Okay. So anything to comment on that, Srinivasan sir, Keshav, Muthukumar sir, Honorary.
The actual history was slow growing only. For the past few months only, they have mentioned it's 1 year. For the past 2 months, and that's also she didn't give any significant in the increase in size.
Yes, sir.
I think it is growing because she developed some mild headache also, and that also on and off headache. She took that paracetamol and over the counter subsided. That's why they didn't stress on that word. I said, what the patient told you tell.
Yes, sir. Yes, sir. Yes, sir. So next slide. So any differential diagnosis you have to think, Robin. Preauricular lymph node, they have told lymph node, if it is so, what disease? So they should think whether it is probably metastatic. 7 years, how it becomes out there, and so they should be able to think of palliative or other things. Nandana, tell investigations, no?
Okay. So the major investigation is ultrasound neck and parotid region. FNAC if the swelling can be done. An MRI of neck is done in order to know the extent and also to stage the disease. And CBC, RBS, RFT, LFT, chest X-ray, ECG, echo. There are the pre-operative investigations because the patient have to be taken for surgeries.
Go back 1 minute. Any question of this, sir, Manohar sir, Muthukumar, Keshav?
Always start with the routine basic investigations. CVC, liver profile, RF liver, everything, the glycemic profile, everything. Then the most common investigation for a salivary gland swelling, which is the most common, most important one.
The ultrasound.
Ultrasound is the most. Will you get all the diagnosis benign? We are worried about the swelling. We are the main thing about the patient in your particular cases. You had a slow growing swelling, sudden increase in size. What are you afraid of? What patient afraid of? Malignancy?
malignancy.
Don't you think FNA should have been the first one?
Yes, sir.
Then you go for your ultrasound, salivary glands and the neck. Okay, you want to look for things. That's it. Fine. Then our question would be, why do you want to go for MRI?
Sir, in order to know the extent and also to stage the disease.
You have told us it's a benign etiology. So what do you want to state?
Nandana,
Sir,
if it is FNAC, what findings are there in histological findings in there? Pleomorphic adenoma? What is specific?
sir, histopathologically, it is a mixed tumor which consists of epithelial cells and mucoid cells.
Okay. That is okay. That is diagnostic.
FNAC must be image ultrasound guided, ma. That you should mention. You cannot blindly put a needle inside. So
Yeah, now it is ultrasound guided.
So ultrasound guided. As Robin said, the MRI you have to have specific conditions for doing
Why
it.
MRI? Why not CT scan?
One
Nandana?
more thing for MRI, what? In which condition MRI is more useful, ma? See, it's parotid swelling. What will get affected? To look for any early involvement of what?
Why you are to MRI specifically, Nandana? Jitya,
What is seen better on MRI?
can you hear us? No, Nandana?
Yes, there.
Nandana, unmute.
Are you able to hear Nandana?
They're off.
Yes, sir. Yes, sir.
Why MRI? The sir is asking.
MRI is good for which sir is asking. What involvement you can see in MRI?
Soft tissue involvement.
Soft tissue involvement, sir.
What are the structures you will get expected to get involved?
Specifically, what you are worried, most of us are worried. Nandana, Jitya,
Carotid,
Yes,
what
sir.
you are worried?
Both of you know.
Deep lobe is involved.
facial nerve. Deep lobe, okay, facial nerve involvement.
No involvement.
No, you are talking about facial nerve.
Location of the nerve, no?
Facial nerve involvement.
Soft tissue nerve involvement. Deep lobe, okay.
It is not MRI of neck. It should include parotid also.
You should neck and parotid region. You are written only neck. Neck and parotid region. Neck and face, okay? Not just neck and face, parotid region. Both you write together. Okay? It is mainly to facial nerve. You didn't say face. And of course, deep lobe, okay? So that's why I'm more relevant. Right. So anything which is important to accepted FNAC, guiding FNAC, then MRI face together region. Because the soft tissue is not involved, and that's absolutely right. So next slide. Anything to add, Robin? That will be sufficient.
Yes, sir. Manoj sir and Keshav sir has added. Actually, that order, it will be easy if you are in order, that's all. Go
Yes.
for routine basics, specific investigations, like almost now every swelling, like Manoj sir said, ultrasound guided FNAC is the norm now. Even if in breast, you go for ultrasound guided true cut biopsy. For thyroid, it is ultrasound guided FNAC. It's always better because when it comes to a parotid, when it comes to salivary gland, especially parotid, we are worried about the nerve. So if you go to the nerve, then we will be in a lot of hot soup. So always is better to have ultrasound. Then we come to the CT MRI. The CT is superior, like SRB sir asked, is it possible to do a CT? Yes, there is. There are specific indications. If you have suspecting early bone involvement, skull, things like that, you
And
go
the
for
and the lymph node CT is better.
yes. But when MRI, you are looking for deep lobe and what Manoj sir and Keshav sir was asking specifically. What about nerve? Nerve is very important. Guys, can you give us two differential diagnoses or two diagnoses where MRI is gold standard? Two diagnoses where we do MRI. Blindly we go for MRI. Which are they?
Nandana, Jitya, if you do not take Robin, you can.
You can answer them.
Very,
Sir, Robin.
both of the diagnoses start with the same letters.
Don't know, sir.
You further or give answer.
So, silentinitis.
No. Why silentinitis? Why do you want inflammatory? No. Neoplasm. Guys, you already told we have deep lobe involvement and we have a nerve involvement. So our question is, are there any neoplasms that you know which catches the nerve, which involves the nerve?
Which malignancy involves the nerve?
They are
Which
notorious
tumor has
for
got
that.
a predilection? Which tumor has got a predilection for nerve involvement?
Most of these patients come with changes.
Which malignancy has got very high activity for the nerve?
Nandana,
You tell the different pathologies, no? Then you will only get it.
what are the other types of carcinoma?
We already told the most common
Pleomorphic
type.
is one. What are the other pathology? What are the other types?
Because carcinoma has got less affinity for the facial nerve, which has got the most affinity for the facial nerve. That's what the-
Which tumor has got affinity for malignancy? The nerve predilection.
Huh? That is
No, I told. No, it
What are
starts
the other
with the
type of pathologies that you can see? One is pleomorphic adenoma. What else? Second
What
most common is what?
malignant or benign? What is tumor?
Benign. Malignant. Arsenic cell cancer.
Adenoid carcinoma. Okay?
Which is the most common malignancy in carotid in salivary glands?
Scar, I will told.
Mucoepidermoides.
Mucoepidermal carcinoma, absolutely right. Which are the two where nerve involvement is very high?
See, nerve involvement is very late. Epidermal carcinoma.
Cause clear?
Adenoid cystic carcinoma, not that.
Adenoid cystic and arsenic cell carcinoma.
Cynic cell.
Both are the same. They start with the same. ACC. Very easy to remember. Both of these guys are notorious for nerve involvement. When these patients come with nerve changes, you just take an MRI, you'll find everything there. Yes, that's it. ACC, adenoid and acidic cell carcinoma. Okay.
Okay.
Yes, sir.
Yes, sir. Next slide. Blood parameter. Next slide. So, just read the finding on the left lower pyramid. Okay. MRI neck, you can see that well circles I have seen superficial over. Okay. The size also there was 2.6, 2.1, 2.9. So it is okay. Some lymph nodes are there. 1A, 1 are there in the MRI. Next slide. Okay. Now here the uncertain malignant potential.
Yes, sir.
That is the FNAC in this patient.
They want a full size specimen.
Okay.
They're not happy with the needle.
They're not happy with uncertain. What if it is uncertain? What you will do, Vandana?
Sorry, sir.
Based on this report, what is the next step for you?
Superficial parotid.
Okay.
Sir, since it's a malignant potential, we go for total conservative parotidectomy, sir.
No. They have said uncertain malignant potential already. They have told no. So,
Yes, sir.
so what option you got? One option is repeat FNAC. Okay, you have to do repeat FNAC. If that is the same thing, what's the next option? Is to do something or do something else. We add on to something else along with that in the OT while doing surgery. Make sure that it is malignancy or not.
When you have doubtful malignancy, what is the option?
No, sir. They have not seen. They have not seen, sir. Please.
Okay. Frozen section. No, on table frozen section. Have in such situation. Okay. Andana, Nitya, on
Yes,
table.
sir.
Here, repeat FNAC. That also becomes same thing. Then you should have on table frozen section facility. Then go ahead with that. Okay. So.
But I think, sir, that is acceptable, superficial parotidectomy, because we are not touching the tumor and we are removing it en bloc. So I think that is okay.
Absolutely right.
Students at MBBS, they tell
Definitely
definitely it's acceptable.
Next slide. So this is what we have written superficial parotidectomy. As per report, malignant change in the gland, total control was done in this page. So their answer is superficial. You thought that, but what is done probably is total conservative treatment. So next slide we'll put, I think. Next slide. Okay, this is what
Yes, sir. The patient had a post-operative complications, sir.
Element type
complications. What are the other complications
Sir,
other than facial?
What are the other complications?
sir, they can have Frey syndrome, fluid collection, flap necrosis can occur, sir, and then there can be fistula formation.
fistula hemorrhage.
And facial palsy. 5 Fs. Very easy to remember. Very good.
Nandana, Warthin's tumor you have, is it benign or malignant?
It's
Warthin's,
benign tumor, sir.
huh?
Benign tumor, sir.
Benign. Seen in which individual? Male or female? Commonly.
Males. Males, sir.
Male. Smoker, non-smokers.
Non-smokers.
It is common in smokers, male smokers. Okay, it is common in male smokers. Okay. So, uh, what incision will put for periodicity? Do you have got any idea? At their level, I think they let them remember superficial total conservative and radical. If they remember sufficient. Now current classification has changed actually, Robin. There are European society classification totally different now. But if they remember it's much sufficient, I think. Superficial, conservative, and radical periodicity. I think. Keshav?
Yes, sir.
Sufficient. But facial nerve palsy, they should remember. Save the facial nerve. What is the identification marks for facial nerve? What is the incision? You
Sir,
heard
it's
of-
lazy incision, sir.
Lazy incision.
Any name for it?
Lazy incision. So how will
It's a
identify
modification
facial nerve?
incision, sir.
Blair incision.
Flare incision.
What are the identification marks for facial nerve? Nandana?
So we have tragal points, sir.
Huh?
Tragal points.
Okay.
And then we have the superior border of the digastric muscle, sir.
Okay. Styloid and
Styloid.
retrograde also can identify the facial nerve. Now ideally,
Which belly of the digastric? Which belly of the digastric?
Posterior belly.
It's the upper part of posterior belly of the digastric. Very good. Yes.
ideal situation, you should use the nerve stimulator, nerve stimulator during surgery, so that will not injure the nerve. That is the thing. Best answer is demonstrate in the during surgery. And many times it will be neuropraxia rather than actual injury to the nerves. Okay, so Preeti put my slide. Meantime, any comments or anything about? Thank you, Srinivasan sir. Thank you for this one. We'll have slides mine. Robin,
Sir,
sir, final
clinically, in the clinicals, without the investigation, I took the class as benign, so I taught them a superficial paratidectomy. When the reports came, I just asked them to add this slide so that we can have a better, one more discussion. So I told them so. That's why they put it. But the histopathological report, I saw it yesterday. It came as only benign only, sir. From the excision biopsy.
Report is fine. Okay, sir. But that FNAC was a hitch actually, so that's why it was justified. Okay. But if it is benign also, you may give the rating, I think. Even benign phlegma will give radiotherapy because we got a pseudo. So that is the thing. So I'll just quickly go through slides, Robin. About just a few comments on their presentation. Robin.
Nandana, it's a very good presentation. It's nice. Just only fine tuning is required. That's all. Whenever we come to a swelling in surgery, always obviously swelling is the main thing, the main complaint. Second thing would be pain. When it comes to a salivary gland, let's say some maybe discharge also might be there as a complication because we do not know whether it's a benign or a malignant problem. That's fine. So the checklist of history and physical examination, please make sure you cover all the points except the congenital thing, infective inflammatory causes, neoplasm, and your fistula, which includes also calcular formation. That's it. Examination, inspection and palpation, definitely. You've covered all the points. Always make sure to see the skin over the swelling. Like all of us saw that scar, but you seem to have missed out the scar. So always make sure you see something. Whatever you see, you have to tell us.
What you have seen in your section.
That is very important because what if that scar was not because of a trauma? What if the patient had undergone some FNAC? What if the patient had developed a fistula opening? What if the patient had developed undergone a biopsy? Any of these things could have caused a scar there and not healed. So please remember that. And any external opening, always very important in salivary. Because we are going to look for discharges. The rest is fine. Bibinal, bidigital palpation, that's fine. Always look for the deep lobe. Always, sir, and all these occasions, sir, always examine the oral cavity. There's no doubt about it. Because if you have a deep lobe involvement, how will you know if the deep lobe is involved? You look for the tonsillar fossa. If it is shifted, then we know definitely the fossa is involved. Very simple. The most important thing which you have missed out is the facial nerve involvement. That is very important when it comes to carotid. Any changes there, you should keep it there itself. So very good. So diagnosis, never try to mention benign etiology because we do not know. We will ask you that. First, like sir said, first question would be, how did you identify parotid? Second would be, how did you figure out if it's a benign pathology? So you give us 2 or 3 points. First, from the site of the lesion, onset of growth, that itself will give you a clue if it's pleomorphic adenoma. It's classic for slow growing with rapid increase in size. And whether it's malignant, there are 10 points, but at least give us undergraduates at least 3 or 4 you can give points in favor for malignant swelling. So that's also fine. Investigation you have given, but try to be in order, because if you put so many like MRI first, PET scan, PET CT first, then you will be in a lot of trouble. Routine specific investigations like Manoharan said, ultrasound guided FNAC first. No doubt you are putting both the things there. Then you go for CT. Then you go for MRI. Last, if you look for metastasis, you go for PET CT if you want to. But at your level, we will not ask too much of that. Then you go for the treatment. There are different types of peritodectomy. For pleomorphic adenoma, like Keshav sir already said, superficial peritodectomy is the treatment of choice. Yes, sir? Srinivasan sir, I think we all agree with Keshav sir also. There is no doubt about it. Superficial peritodectomy. If you have a deep lobe involvement, you go for what you said, total conservative also, that also we agree. If there is a facial nerve involvement, that is the only additive feature, then you are forced to do a radical peritodectomy. For postgraduate, we go for a little bit more for functional, but I think at your level, you have answered all questions. Yes, I think full credit to Srinivasan sir. The teaching and training is excellent. Yes.
Sir, 1 minute, sir. I can tell you the histopathological report. It has come to be possibility to consider benign salivary gland tumor, probably cellular pleomorphic adenoma or myoepithelioma. IHC may be done for a definite diagnosis. And the deep lobe is the parotid shows no specific pathology.
So it only for superficial lobe.
The case was done by an oncologist, sir. He said it's better you remove it since it is some for.
Absolutely.
That's a final pathology report, sir, which we are not. I have not told the undergraduates.
Yes,
sir. Muthukumar sir, any comments on the student presentation?
Already told by Dr. Robin sir.
Yes, sir.
In parotid case, you have to examine oral cavity, neck nodes, facial. That's all.
That's all. And other salivary glands.
Other
They
salivary.
presented well. Initial inhibition they had, but later they got adjusted. They should learn to answer the questions, analyze each word, whatever they are important. Analyzing and giving reasoning. Reasoning is most important. Keshav, anything to?
No, that's okay, sir. I think the presentation was fairly okay.
Fairly okay, sir. Slides are done it well. Manoharan sir.
Yes, sir.
So I'll just quickly go through my slide, Robin, for a few minutes.
yes.
Both Nandana and Nitya did well, sir. But only the run through is good. But Robin has very well summed up all the things. So inspection palpation, you have to be a little more specific and meticulous. And remember, the other questions they will ask is, what exactly is superficial peritodectomy? What is superficial peritodectomy?
What? Nandana?
No, you said that the treatment is superficial peritodectomy. What do you mean by superficial peritodectomy?
Superficial lobe alone is removed, sir.
So you must
How do you divide the superficial?
superficial to what?
Superficial to what?
These are
What divides?
basic questions they will
What
ask.
divides into superficial and deep lobe, ma?
So the facial venous vein pads.
Exactly. So these are things they will ask you. And I think you mentioned about Fraser syndrome. What is the symptom, classical symptom associated with Fraser syndrome?
So sweating at the site of
What sweating? What sweating?
respiratory sweating.
Respiratory sweating.
That's
So these are certain small questions you should know. And always keep the oral exam, intraoral examination separately. We need inspection, palpation outside, then talk about intraoral examination, as Robin sir said. You would have to be thoroughly seeing the bulging, swelling, translar fossa, the peritodectomy opening, all those things you must see. Otherwise, run through is good.
Sir, we'll just go through my slides.
Yes, sir.
Preeti, next slide. So these are the main things you have to remember: major salivary gland, minor salivary gland. I'm going to detail it. Most important, facial nerves are most important. Other nerves are for submental salivary gland, hypoglossal, lingual, and marginal mandibular nerves are important. saliva from serous mucus, all those things are mainly MCQ wise, it is important. Remember, tensions duct where it not, and Wharton's duct is for the submundular gland, and venous, facial venous plane of Patey. It's already discussed. Manon sir discussed. Pest answerness again, how facial nerve configures. That's also discussed. Next slide. So history exams are local, facial nerve, other salivary gland, neck node, and the systemic exam is the order actually. Of course, it's the oral cavity examination. Next slide. Next slide. So name, age, all these things are already told. Next slide. Chief complaint. Next slide. Swelling, excessive salivation. In this order, you have to mention pain if it is there, fever, facial nerve if you need duration. With the duration, order it's important. In this order, you have to always mention chief complaint. Next slide. History taking of the facial nerve involvement, drooling of saliva, enabled closed eyes, tears in eye, asymmetry of a difficulty in opening the mouth. All these things are important in carotid swelling. Next slide. Next, so different types of facial nerve involvement. See, carotid involvement. This is the submundular salivary gland. This one. So next slide. So swelling, all this history we have discussed at site, mode of action, swelling, duration with the pain, when pain appears. Recent increase in size is very important. That is what we have discussed already. Additional life of slow graying in the lower pole, bilateral enlargement, already we have discussed different syndromes, everything we have discussed, Jogren-Mickle syndrome. So same thing is important. So other salivary gland exams also equally important, submandibular, other side parotid, and so on. Next slide. So pain again important. We have given important back duration, severity, radiation, sudden onset, throbbing pain, everything discussed. Colicky pain means maybe salivary calculus. That is again that point here. Salivary colic it is called as. Next slide. So recurrent painful swelling and swelling in the submundular region. We have discussed all those things. Fever again, fever we have discussed. Keshav has discussed in detail. Abscess, whether it is suppuration is there, which is common. All those things again. Abscess is usually one side. Mumps will be bilateral, and pneumoplastic conditions are usually one side. If there is a necrosis, it can cause fever. Also, the different reasons why fever can happen. Can develop in salivary gland. Next slide. So other history, different opening the mouth and excessive salivation, discharge, dry eyes, enlargement, other salivary glands. You already they have mentioned actually. Past history, person, alcohol and diabetes, and bulimia, eating disorder. It is there. We have discussed that. Sir has discussed why bulimia. And drugs actually, antihistaminic guanethidine has got some relevance as far as saliva secretion, especially in bilateral parotid. And sclerosis, selectasis, you have to remember, bilateral parotid. But cirrhosis, all other conditions, they will have bilateral fatty infiltration of the parotid. And same thing, selectasis. Next slide. So these are the things. Next slide. So with the oral cavity, already we are told a relevant with the must with the neck lymph node. This point already mentioned there. We have discussed very clearly. Next slide. Look, next slide. So this is the example. This slide is important. In the table, I have put swelling lies below, behind, and in front of the ear lobule, upward right of the ear lobule, and clenching of the masseter contraction, size, shape, surface, edge, and all those where you will palpate tension of the duct. Very clear. Surface, scar, ulcer, scar. They have missed. They have seen, but they didn't mention. Whatever seen could be mentioned. Next slide. Next. So swelling palpation, again, same thing. Local surface, consistency, it will have different fluctuation if it is abscess or cystic swelling. Mobility fixed to deep, that's already discussed. Because the curtain sign is important. Deep lobe palpation is the bidigital. For the duct also bidigital often it is called as. So next slide. So these are the different clinical methods how we will check for the parotid swelling. So this is bidigital of the parotid duct also, and mobility, and of the deep lobe also. Different way to examine the ear lobule results very clear. Next slide. So again, palpation inside the oral cavity, clenching of the teeth, eye, facial nerve, how to check the facial nerve. That's important. How exactly eyebrow, eyelid, then clenching, then blowing of the. These are if these three things if they do, probably facial nerve is intact. Very easy, very simply, very easier to check. Eyelid, clenching, and blowing. If it is there, mostly facial nerve is normal. And lymph nodes are important. And submundular salivary gland, again, bidigital palpation for the submundular salivary gland to differentiate from the lymph node. Submundular lymph nodes are not bidigital palpable. whereas submandibular salivary glands are bilaterally palpable because it has got a superficial and deep lobe, which is across the mylohyoid muscle. That's the reason. So same thing you have to check. Next slide. Next slide. So this is the different thing. This is the best science and authoritative finding. Facial nerve, how exactly it looks like. This is the laziest incision, or the modified layer, or often called as six trunk incision also. So facial nerve palsy, already we have shown the photo. Sir has shown the photo. Jason sir, and different things. You can see the submandibular duct here opening with the inflammation there, also in the floor of the mouth. So next slide. Examples of facial nerve, I'm not going to detail it. All those things are discussed already. Plane also, facial nerve plane of platy also important. It's how to identify. All those muscles are important. In the exam, they may ask orbicular oculi, frontabilli, corrugated superficial. They are actually mentioned that frowning, absence of frowning, and blowing, eyelid closer or not. Next slide. So upper face, lower face, that is how we segregated clinically. Buccinator is important. Puffing of the cheek is difficult. Orbital varices, whistling is difficult. Levator angular varices, deviation of the opposite side. And the platysma, stretching is difficult. And this how we will check different muscles in the upper face and lower face in relation to the facial nerve. That is also clinically important. Prevalently, mainly postgraduates, of course, exam can be asked. So you should have the clear idea about these muscles, how they act. Next slide. Next. So this is the which muscle, when it becomes what weakness occurs, which action, which muscle is related to which muscle, which action. I'm just put in the slide. Next slide. Same thing, inability below, buccinator muscle, and orbicular varis, whistling. So whistle, puffing, closing of the eyelid, clenching. These are the four things. If they do, if the patient can do, means the facial nerve is intact. Whistling, puffing of the cheek, closing the eyelid, and clenching. So 4 tests if you do very easy. Within few seconds we can do that and say facial nerve is intact. So supranuclear, infranuclear palsies they may ask in the exam or MCQs. That's why that's important. So basically, that's the next slide. Next slide. So other exam, jaw movement, isthmus, temporal artery pulsation is important, which you have forgotten actually. We should always check the temporal pulsation, carotid pulsation, taste sensation, how to check also salt, sweet. They have told sour, and which nerves also, bitter taste for the glossopharyngeal nerve, and quinine on the posterior of the tongue also, hypoglossal nerve, spinal if there is a lymph node involvement, cervical lymph node is the other system examination. Next slide. So right side apparatus swelling, pleomorphic adenoma, microcarcinoma, or keep in mind differential which I already discussed. Ultrasound neck, CCT, MRI, all those things we have already discussed. If it is metastatic workup with the PET CT or chest CT, abdomen CT, and so on, depending on the individual case by case basis and situation as such. Again, periodectomy, superficial, total conservative, radical, functional, suprafacial, all those newer terminologies are there. If the student UGs, they remember superficial, total conservative, radical, that is more than sufficient, I think. Other thing, functional also still popular now, suprafacial also popular. Now, newer classification has come for periodectomy, European guidelines. That is not necessary for UGs, of course, may be useful for the maybe required for the postgraduates. Next slide. So that is about briefly about the parotid salivary glands. Very common long case or short case for the UGs. Complex structure. Main thing is facial nerve. So everything in detail we have discussed. And I thank Srinivasan sir for making their student present and getting involved. Thank you very much for sir for joining us. And
thank you, sir. Thank you, sir.
Thank you, sir. Thank you. I request students subscribe my free actually. Already student lectures are there. I thank my guru Manohar sir. Sir, always he is very supportive for me. Buddha Kumar sir is always please join regularly. His clinical ideas are very relevant for us. Keshav is a good with this, of course. Scintillating, Robin is scintillating and with a lot of very thinking. Excellent this one, so makes things very well. I thank everybody. Without you people, sir,
1 minute, sir.
Sir,
1 minute. We can ask the students if they have any doubts. We got a panel of galaxy of experts.
Sriram sir.
Still, they are left. I think.
Srinivasan sir is very senior faculty, sir. Our senior colleague from Coimbatore Medical College, HOD.
Yes, sir, yes, sir.
So he is,
I,
teaching faculty in all our ASA conference for so many years.
yes, sir. My profile I have written is numerous.
Nice to see him back after so many years.
Yes, sir.
In fact, I have been trying to get him to my college
Yes, sir.
after retirement.
I still
Sir came for my retirement.
in my mobile I have written Srinivasan sir Coimbatore. Like that.
Yes, sir.
Yeah.
He is very popular in Tamil Nadu as a PG, EG teacher.
Preeti students are left or there? Nandana and
They have left, I think.
Left right.
Vandana?
no, they are left. I
Yes, sir.
sir.
No problem, sir.